Hello everyone, I'm Dr. Martina John and I'm delighted to be joining you all today as a resource person of Movement Maestro Academy for World Physiotherapy Day celebration. Thank you, Dr. Pradyot sir, for having me. I'm looking forward to a productive and engaging discussion on the topic menopause and musculoskeletal health. Let us dive in and explore the world of physiotherapy together. Now I'm going to share my screen with you all as our topic is menopause and musculoskeletal health and why it matters. I'm sharing it with you all. Yes, I'm Dr. Martina John. I have completed my bachelor's master in orthopedic and I have done my post graduation diploma in on-field sports injury management from Chennai. I'm a pelvic floor rehab specialist and recently I'm working on an orthopedic setup. So we are starting with a menopause. So when we will call it as a menopause and musculoskeletal health, a comprehensive overview of how menopause impacts bone density, muscle mass, joint health, and prevention strategies. So we'll start with the definition and the process. What is menopause? Menopause is a natural biological process marking the end of the menstrual cycle. When it has been diagnosed after 12 consecutive months without a menstrual period, preceded by perimenopause. This is your transition phase where up and down comes. And once there is continuous 12 months, consecutive 12 months of without any menstrual period, will diagnose it as a menopause caused by natural decline in the reproductive hormones. Hormone changes, the main hormone that supports the woman life's after menarche is estrogen, progesterone, luteinizing hormone, follicular stimulating hormone. But as we approach towards the menopause, the hormonal changes happens and the most important hormone, that is estrogen, that has a great impact on our body from muscles, bones, nerves, and organ. Everywhere estrogen has got its own impact, but due to its decline in the production, so there are multiple impact on body system, and especially we have seen its major impact on the musculoskeletal system. But menopause is a natural transition and it is not a medical condition. You have to keep that on mind. Average onsets of age of onset is 51 years, and typically it will range from 45 years to 55 years. And it has been seen that future prediction is there 1.3 billion women maybe in future will be affected globally by 2030. So, menopause definition we have known, like continuously, if there will be a cessation or 12 consecutive months, if will not go with any menstrual period, that it will be diagnosed as menopause. And now menopause will be dividing into three phases. Phase 1 is perimenopause. Perimenopause, where the transition begins 4 to 8 years before the menopause. But just the time period before menopause, that will be your perimenopausal phase. Then we'll come to menopause, point in time 12 months after final menopause period, and then postmenopause. Postmenopause, after 12 months of complete cessation in your menstrual period, and that after that, the years following menopause is postmenopausal phase, where 1/3 of the female life lifespan they feel this postmenopause phase go through. So, in the introduction, the musculoskeletal syndromes of the menopause. Wait a second. So, in the introduction, the musculoskeletal syndrome of menopause. In this introduction, will particular focus on musculoskeletal problem that completely affect during menopause, is a newly recognized constellations of symptoms links to estrogen deficiency affecting 70% of the menopausal women, and this 70% of the menopausal women are getting impacted due to decrease in the estrogen hormone, impacting their bone density, muscle mass, joint function, and overall musculoskeletal health. So the key component of the syndrome will be there will be loss of the bone minerals density, and it will lead to osteopenia and then osteoporosis. Then decrease in the muscle mass and the strength, we call this as sarcopenia. Then joint pain and inflammatory changes and arthralgia. Fourth is accelerated musculoskeletal aging without structural finding. Early recognition is key to prevent and treatment. So as soon as we, if some, as a physio, when we come, some patients comes to us and they are in this period of that perimenopausal or in the menopausal phase. Our role is much more important in helping them to rule out their musculoskeletal problem in whatever they are getting loss of bone density, or they are going through decrease in the muscle mass, or joint pain, inflammatory changes, and we are there to support them with our proper physiotherapy protocol, what we are planning for them for bone pain, joint pain, muscle mass decrease, or osteoporosis. Hormonal changes. The main hormone that supports during womanhood is estrogen. It has great impact on our body. And that's the role of the estrogen. What are the main role of the estrogen in our body? Estrogen and the musculoskeletal health system. Estrogen receptor present in bone, muscles, and joint and tissue. As we all know that there are receptors of estrogen. They are present in muscles, bones, and joints. And these receptors, after receiving the estrogen, help in regulating bone formation and resorption balance, and maintaining the muscle mass and stimulating satellite cells function. Act as an anti-inflammatory agent in joint and cartilage. As they are acting like an anti-inflammatory agent in our joint and cartilage, the rear and tear process of the ligaments and the joints, they are delayed or they are protected with the help of this estrogen hormone. Once this hormone estrogen started declining during the menopause period, the anti-inflammatory agent that are present, they get declined, and much more chances of inflammations are increased during this period. That's why females at the age around 45 to 50 or 50 to 55, they complain for osteoarthritis, they complain for inflammatory pain in all the joint region. So see, when we'll see this, the level of estrogen, perimenopause, premenopause, perimenopause, and postmenopause, they gradually go on decreasing with it. So timing, estrogen began decline 4 to 5 years before final menstrual period and decreased up to 85 to 90% during the menopausal transit. मतलब 85 to 90% of the hormone estrogen gets start decreasing. So we are left with 10 to 15% only. And in this 10 to 15%, estrogen does not have a great impact as compared to 100% of the estrogen. So we have to keep a main thing here, keep in mind that estrogen is a key regulator. It is a key regulator of musculoskeletal health throughout a woman lifespan. So what will be the effect as it is getting declining? So the effect of estrogen on the bone will be how it helps the bone. It helps in accelerating bone resorption, increasing bone turnover, net bone loss of 10 to 20% in the first 5 to 7 years after menopause. Then its effect on muscles: decrease satellite cells proliferation, 30 to 60% reduce muscles protein synthesis. So if there will be no muscles protein synthesis, uh, person will lack the muscle mass and will lead to sarcopenia. So सिंथेसिस ही नहीं हो रहा है तो अगेन लॉस ऑफ सिंथेसिस, बिकॉज वहां पर मसल्स प्रोटीन का सिंथेसिस हो ही नहीं पा रहा है, then that can lead to inflammation, that can lead to sarcopenia. Then what will the effect on joint? It enhances inflammatory responses and decrease cartilage recycling, reduce synovial fluid production. So overall, when we have seen this, the effect of estrogen, as a estrogen get decline, it will affect, definitely it will affect your bone, muscles and joint. So molecular mechanism, where we'll see up regulation of the pro-inflammatory cytokinins, activation of the rankle paths, increasing osteoclast activity, and impaired mitochondrial function in the muscle cells. Then reduce collagen synthesis in the connective tissue. As you all know that our body collagen system, the collagen component are main role player in the muscles. Type 1 collagen and type 3 collagen as we'll compare. But during menopause, what happened? This type 3 of collagen, which is much more responsible for your elasticity and flexibility in the muscles, that start getting reduced. And we are left with collagen 1 fiber. 1 fiber is much more rigid type of fiber and it is present mostly on ligament, tendon and bone. And type 3 collagen are present in like organs, in muscles. So reduction in the collagen 3, type 3 collagen decreases the flexibility. And just because decrease in the flexibility and elasticity, we are left with rigidity and stiffness all over the body. Now, looking into the bone health and osteoporosis, menopause and bone loss, they both are connected, because during menopause we are now not having any estrogen. So definitely the bone health will get affected, because some or the other way estrogen was a key component of maintaining our bone health. Okay. Now, as menopause, we have reached into the age of menopause, it will have a great impact on the bone health, and at the end, we are left with the deficiency of estrogen, and that will accelerate your bone loss and increase the risk of fracture. So, as we approach into the age of menopause, many women complain of sudden, in standing only, they got fall down and fracture happen. So just because of deficiency of estrogen, that will accelerate bone loss and increase the fracture risk. Up to 20% of the bone mass can be lost within 5 to 7 years after menopause. It is a rapid but a slow process. जल्दी जल्दी होगा and धीरे धीरे like it will take time, and at the end we are left with osteoporosis. Rapid loss, phase 1, affect primarily the trabecular bones, and slow loss will be the phase 2. It will affect both trabecular and the cortical bone. Now, when we'll see normal bone will be have dense structures. The trabecular system of that bone is very much strong during this period in normal bone, but it will slowly lead to osteopenia, and will score like 1 to 2.5, and then total score will see in a sarcopenia, and then osteoporosis that will be less than 2.5. It has a clinical impact. Why it is having a clinical impact? Because it is increasing the risk of fracture, then reduction of the height also, then kyphosis, and then decreased quality of life. And why the quality of life is decreased? Because some other way your bone is affecting. You are now left with the strength in the bone. So fracture and all that, that will definitely, you will suffer or go with pain at that time. So the quality of life is also affected. So early identification and intervention are crucial, preventing fragility fracture. 50% of the women over 60 will experience osteoporotic fracture. 10% BMD decline in first 5 years post-menopause, and then 3% uh, there are 3% more chances or higher chances of women than men, because women are much more affected during menopause. So what will be the pathophysiology? Pathophysiology, estrogen effects on bone. What are the pathophysiology? It regulates bone remodeling, inhibits osteoclast activity, promote osteoblast functions. You all know that osteoclast activity and osteoblast activity. Osteoblast, there is a formation of bone cells, and in osteoclast, there is reduction. So, estrogen inhibits the osteoclast activity and it's promote the osteoblast activity. So, जब तक estrogen रहेगा, there will be a process of formation of new bone group. Okay. Then during menopause, it enhances the osteoclastic resorption with decreased osteoblastic formation. So just opposite, menopause में क्या हुआ, यही चीज जो हमारा osteoblast और osteoclast की जो एक्टिविटी थी वो कहीं ना कहीं इफेक्ट हो जाएगी, फॉर्मेशन कम हो जाएगा और ब्रेकडाउन ज्यादा हो जाएगा, तो बोन वीकनिंग में चला जाता है. Cellular mechanism, increase inflammatory cytokinase. Okay, that will lead to stimulate osteoclast activity. Biochemical changes, it's elevate bone turnover maker index, accelerate bone loss. So look into the graph. It is a statistic and epidemiology. While seeing this, the rate prevalence of bone density across menopausal state, when you'll see from starting from perimenopause up to the postmenopause, there is a gradual decrease in the bone density. See, gradual decrease in the bone density. Okay, that will start from osteopenia and then finally up to the osteoporosis. So 30 to 50% bone density loss within first 5 to 10 years after menopause. Annual loss of muscle mass after menopause without intervention, that is 0.6 percentage, and 8.9 million fractures annually worldwide due to osteoporosis. Global impact, overall in a global impact of osteoporosis, 200 millions plus million individual affected by osteoporosis worldwide. Out of 3 in 1, out of 1 in 3, women over 50 will experience osteoporotic fracture, and 5 out of 1 men's over 50 will experience osteoporotic fracture. Now, 80% of the osteoporosis patients are women due to menopause related bone loss. See the graph here, from 45 to 50, then 50 to 55, 56 to 50, 56 to 60, 61 to 65, and 66 to 70, then 70. As we approach forward into the age from 45 to 70, there is a sarcopenia prevalence rate is getting much more higher according to the age. Okay, so it's very definite that the role of estrogen is important in bone, muscles, and joint. So as we go older with the age, And after menopause, there is a great risk of osteoporosis and osteopenia and osteoporosis, and the greater chances of fracture. Then the risk factor for musculoskeletal decline post menopause. What are the risk factors? Some risk factors are non-modifiable risk factor and some are modifiable. नॉन मॉडिफाइबल में ऐसा हो जाएगा जिसको हम मॉडिफाई नहीं कर सकते, द एज, देन जेनेटिक्स, देन एथनिसिटी, देन अर्ली मेनोपॉज, बॉडी फ्रेम एंड प्रीवियस फ्रैक्चर. एज एक्सेलरेट बोन एंड मसल लॉस आफ्टर मेनोपॉज, दैट इज डेफिनेट. एज बढ़ेगा तो एज के साथ कहीं ना कहीं बोन का डिजनरेशन प्रोसेस भी होगा, मसल लॉस भी होगा मेनोपॉज के साथ. जेनेटिक, if there is any family history of osteoporosis and sarcopenia, definitely it will be their genes that will affect. Ethnicity, higher risk in Caucasian and Asian women compared to black women. Early menopause, early onset, increased long-term risk. At an exact rate, if it will affect, that will be good. But if that age is the onset of that menopause is early, then it will have a great impact and the long term risk the woman has to suffer. Body frame, small framed women have less bone mass to lose, and previous fracture history increases the future fracture risk. Modifiable risk factor, the things that can be modified, that is the physical inactivity, means if the person is having a sedentary lifestyle, that will accelerate muscles and bone mass loss. If you're not moving, you're sedentary, you're sitting for a long period of time, you're not moving your limb, you're not getting up and moving your joint, then definitely in a coming life span, your what you're affecting your muscles and the bone loss. Low calcium intake, nutrition is much more important to be taken care of. So low calcium intake, definitely you are not taking inadequate calcium, that affects the bone mineralization. So calcium intake has to be kept in mind as it is one of the major nutrition, that is mineral nutrition and a mineral for your bone health. Inadequate calcium intake can also affect the bone. Then vitamin D deficiency. Vitamin D deficiency impaired calcium absorption and bone formation. If somebody is lacking with vitamin D also, and if they have started taking vitamin D along with calcium, definitely it will support your bone. But it is a modifiable risk factor. We can modify here by taking the supplement, by adding it into our nutrition. We can have this modified. Smoking, smoking as it decreases the estrogen level and accelerate bone loss. If person is having an excessive alcohol intake, that will also interfere with the calcium balance. If you are not taking protein, much more low protein take is there, then definitely you will getting your muscles impaired, impaired muscle maintenance and recovery. Medical and medication factor, long-term corticosteroid use. If somebody is using long-term corticosteroid, thyroid condition, rheumatoid arthritis, malabsorption disorder, or certain cancer treatment, that will have a great impact on your bone, muscles, and joint. And it will directly affect your menopausal phase also. Now we have known much more thing because हमने ये जान लिया है कि how menopause is affecting your overall musculoskeletal structures, and this estrogen is main component of support for your bone, muscles, and joint and nerve, everything, because everywhere we are having muscles. uh, Smooth muscles are there, skeleton muscles are there, smooth muscles to help organ move, and skeleton muscles for support and movement. So everywhere we are with smooth muscles and fascia. So the impact of estrogen is everywhere, because everywhere receptors are present in our muscles and in our ligaments, in our bone also. So this, if this one minerals, this one hormone is getting decline in our body, it will have a great impact on our musculoskeletal health. So at the time when we have early recognized that we are approaching the age of perimenopause or menopause, we will definitely try to take a preventive strategies, and it has to be overviewed. A comprehensive approach to preserving musculoskeletal health during and after menopause required multiple integrated strategies that address modifiable risk factor and maintain bone and muscle integrity. As you all know that mental health is also affecting during menopause. Patients go with frustration, stress. So mental health is also affecting, because the changes that females go through this, they are never expecting it. And once they start suffering the pain, their mental health is getting disturbed. So multiple integratedly strategies we have to keep in the mind while treating the menopausal patient. We have to support them physically, we have to support them mentally and socially also, because it has been kept a taboo of not talking about this condition everywhere, because this is affecting muscles everywhere. But the main cause is that females are not coming up or talking about this condition, or they are suffering in silent every single pain. So to support, we as a physios, definitely we have a main role here as a physios to support them mentally, physically, and emotionally also. So comprehensive prevention approaches where we are encouraging them for physical activity, targeted muscles regime to maintain bone and muscle mass. So much more weight bearing exercises they will be doing, the strengthening programming, the progressive resisted training. We have to advise them and to maintain that bone strength and muscle mass. And nutritional optimization with adequate calcium, vitamin D, and protein intake, timely pharmacological intervention including hormone therapy consideration, because hormone is now lacking, so they can additionally go with a hormone therapy. And regular screening and early detection of bone and muscle loss can definitely help them to cope up with the situation of menopause. Nutritional interventions, when we talk about nutrition intervention, there are the key nutrients for bone health, that is calcium. And the requirement of calcium is 1000 to 1000 1200 mg daily for postmenopausal women. Vitamin D 600 to 800 international unit daily. Magnesium 320 mg daily to support calcium metabolism. Vitamin K2 support calcium deposition in the bone. So the sources of calcium, they can get it from dairy product, fortified plants, milk, then green leafy vegetables, then sardines and bones, tofu, calcium sets. Then vitamin D source are sunshine exposure, fatty fish, egg yolk, fortified fruit supplements when needed. Sunshine is very much important. At least 15 to 20 minutes of complete exposure on the sun is been advised for the absorption of vitamin D, and that will help in maintaining the bone health. Then we have one with the bone health, then again we have to maintain the muscle mass also, because there is a sarcopenia, loss of muscles during this condition, and we have to advise them to take protein to prevent muscles for the preservation of the muscles health. High protein intake 1.1 to 1.2 gram or kg body weight. According to body weight, they can go for, if somebody is having a 60 grams, 60 kg, then they can go for 60 gram protein in their diet. Quality protein at each meal aids muscle maintenance, essential for preventing sarcopenia during menopause, combined with resisted training for optimal result. So magnesium sources are there from where they can get, and in a day 300 to 500 mg may benefit the bone health, because magnesium is very much important for the calcium absorption, and magnesium has a great impact on all the organ and the muscles also. Calcium is helping in contracting, magnesium in helping in relaxing. So both component has a great role and impact on your bone and muscles. And vitamin K2, that is the source where they can found. And you definitely add this source. Nutritional intervention will have a great support on the female overall health. Now, our exercise play a major role here. We as a physio can plan, can make a proper diagnosis about the condition of the bone muscles. We can have a girth measurement. We can see the osteoporosis or osteopenia condition of the bone. And according to that, we can advise the patient for exercise. So there is exercise based guidance. Means if a person is coming and they have been diagnosed with perimenopause, you can start off with the exercises and guide them that you definitely you have to do some strengthening exercises using the weight. So when we do weighted exercises, they have a great impact on our bone. So bone health uh, can be recovered with the use of weighted exercises, and then gradually you can prescribe them with the progressive resistance training. And the frequency should be 3 to 5 days per week of combined activity means you must help them for do cardio also, you can help them for doing strengthening also, you can ask them for doing stretching also, then endurance training, and along with that breathing training. Then intensity, moderate to vigorous. 5 to 7 on. If there is a 10-point scale, then 5 to 7 you have to do. Duration, every day 30 to 60 minutes per session, 150 plus minutes per week. Progression, gradually we have to increase the intensity over 8 to 12 months. Resistance training, weight bearing exercise, balance and flexibility. And if patient is coming with pain, they are having a severe pain in their joints, weight bearing joints like knee joint, ankle joint, hip joint, then you can progress. You can definitely help them for hydrotherapy. Hydrotherapy has less that ground reaction force is reduced in hydrotherapy, and that will give much more benefit when they will do strengthening in water. So benefit of menopausal women: bone health, muscle health, joint health, and reduce the fracture when they will have a proper strengthening training, and they will have a great and strengthening training should also include core muscle strengthening, because core plays a major important role in overall spinal stabilization. So the role of core has to be keep on mind. Their diaphragm has to get activated, their pelvic floor muscles have to be properly made contracted and relaxed, anterior abdominal muscles, and then posterior multifidus muscles, they all make up a core component. And if we'll go with the core stabilization exercise, core activation exercise, then it will have a great helpful during menopausal phase. So, bone health, slow bone density loss by 5% as compared to sedentary women. If a person is coming and they have started with exercise, definitely the loss that she has to go in upcoming year has been reduced. If we'll compare that, so the person, female who is sitting or doing the sedentary lifestyle, she is without any exercise, she will have much more bone loss as compared to the woman who has started with the exercise. Muscle health preserves up to 3% muscle mass and increase strength by 20 to 40%. Joint health reduce arthralgia symptoms by 30%, and fracture risk fall risk by 30%, and hip fracture risk by up to 40%. Why the risk of fracture is increased in this condition? One point I have to tell you, that I have told you the type of collagen fibers, type 1 and type 3. So there will be decline in the collagen 3 product fiber production. So the flexibility and the elasticity of that particular area will be reduced. So it will have a great impact on the fascia. Fascia start getting rigid or tightened up, it will get stiff. And once the fascia get and you know that the fascia have a great covering all over the body from top to bottom. We are connected to each and every part through fascia, and the main thing that get affected is the plantar fascia. The plantar fascia when get affected, we the very first part that come in contact with the ground is the foot. So once the foot ergonomics changes, or once the foot biomechanics changes, it will have a great impact on your knees, hip, back, and upper part also. So facial release technique will definitely help during this period. You can go for myofascial release technique. You can help for lymphatic drainage technique. Multiple approaches as a physio, you can help them. And the line, facial line that is running like anterior, superior and deep chain, posterior, deep and superficial and lateral, then spiral. You must be knowing about this facial line. And facial line, according to that, you can plan a exercise plan so that overall body strengthening can be done. In a core stabilization or neurokinetic exercise techniques, we use to strengthen this women's during menstrual cycle and have a great result. And once I have seen that, working on the foot system for the balance and the coordination along with pelvic floor muscle strengthening, that will support great to women's, because during this periods the muscles sarcopenia is happening, muscle weakening is also there, and the affected organs, uh, that will be urinary bladder, uterus, rectum, female complaints of constipation and prolapse, incontinence. So we have to keep everything in the minds, each and every muscles we have to strengthen. We don't forget pelvic floor muscles, because pelvic floor muscles is forming the floor, and it is acting like a diaphragm, a top diaphragm, down diaphragm. It is matlab ki storing the intra-abdominal pressure, maintaining that intra-abdominal pressure. And once these muscles get into the weakness, there will be a disturbance in the pressure system in the intra-abdominal. So they will definitely have constipation and incontinence problem. So safety consideration, the exercise which you will plan will be in a progression. Start with low intensity and then gradually progress. Include proper warm up and cool down, and proper warm up, then proper stretching, then breathing, then you go for exercises. That has to be in a sequence, because most of the females when they come, they have a shallow breath, and please advise them for going to deep breathing system and proper diaphragmatic breathing along with the core activation. Then you can consult a healthcare provider from starting a new exercise. Means physios can guide them during this also. And here come the major role of a physiotherapist. You can individualize the treatment plan according to the specific symptoms. They are coming with joint pain or muscles weakness. If they come with a joint pain, so first you have to start the treatment, palliative treatment, where we have to reduce the pain first. You can use muscle tense, then you can provide with heat, you can give laser and other modality treatment. And once the pain reduced, you can start with isometric exercises with proper warm up, then stretching, then isometric exercise, isokinetic exercise, then progression resistive training you can provide to that woman. Implementing a mix of exercises, that can include mixture of exercise. You can go advise them to go for a Pilates training also, then manual therapy you can give, and advise them for a lifestyle modification. We have to collaborate with other healthcare providers like dietitian, nutritionist, or any other person where we are finding they can be help out, because we as a physiotherapist, we can support them in maintaining their strength, maintaining their range of motion, and providing them mental satisfaction. But other than that, nutritional support can be provided by nutritionist, or medical if they need any hormone therapy and all that, so gynecologists are there. So multiple healthcare provider are there for support. So we have to collaborate with each and everyone and can help that woman for a proper life being. Support a holistic approach to care means you have been seeing that where we have to work as a physio, we have to work on maintaining their strength. So we can start with resisted training. Here resistance bands are there, 8 to 10 exercise we can prescribe them in a day, and 2 to 3 sets, 8 to 12 repetition according to the condition, if she is able to perform it. So gradually we have to increase the intensity and the resistance. Then weight bearing exercise, we can ask them to go for walking, jogging, or stair climbing if she is able to do. Or best is that she can start with a hydrotherapy in a weight bearing position. That will um, uh, help in maintaining the strength of the muscles. Then flexibility exercise, because I have told lack of collagen, there will be loss of flexibility. So to maintaining the facial elasticity and the muscles flexibility, we can go for a full range of motion stretching and yoga. Then balance training is very much important, because the chances of fall during this period is much more, and we can guide them for balance training. Coordination exercises are there. Definitely ask them to do a balance training, left and right they can go for, a single leg balancing they can go for. So we are a supporting systems to them. We have to support them physically, mentally, and socially. So if they come with this problem, if they rule out that, and if we are able to guide them during this period, that will be much more helpful. So I'm ending up my sessions here, and thank you everyone for listening me patiently, and thank you again Pradyot sir for giving me this opportunity to share my view on menopause. Thank you.